So when we talk about a goal-directed approach to the left ventricle function, how do we know how the LV is working? Well, there's different techniques. Many of these are not going to be tested on the board exams. They're done for advanced echo. You could use what's called the left ventricular fractional area of change. We'll speak about that briefly. You could use something called a MAPC, mitral annular plane systolic excursion. You could use the left ventricular outflow tract shortening fraction. But on the critical care boards, in the medical ICU, of course, eyeballing is going to be the most practical thing we do. And I know anytime we talk about how is the left ventricle doing, people will say words like cardiac output, stroke volume, and ejection fraction. And let me just say that it's not as practical to measure ejection fraction, especially for what we're using it for in the medical ICU. The exact number, ejection fraction of, 62% is, sometimes irrelevant and sometimes misleading. What I really want to know is, how is the heart functioning? Is it good? Is it poor? And combine that with all the other data, history and physical and clinical suspicion. So the eyeball method, it's using terminology, like I just mentioned. How is that LV? It's good, it's normal-ish, it's horrible, and to make the right next step to help the patient feel better. So one of the common things I'm sure we hear people say when they're doing their ultrasound of the heart is they're looking for wall motion abnormalities. Now, I wanted to explain, what is a wall motion abnormality? Well, you're really looking for something called endocardial excursion. So when we talk about, the wall of the left ventricle, it's made of the outer part, the epicardium. The myocardium is going to be the biggest part. And of course, then you have the endocardium. And when we talk about endocardial excursion, the left ventricle, when they have systole, the endocardial motion represents the motion, which means excursion of the endocardial segment towards the center. So when you have systole, you're contracting, everything should go towards the center. When you contract, all the wall should go what? Towards the middle. So you're looking for that to see if all the walls are going towards the middle. And normal LV systolic function is expressed, by having a normal endocardial excursion in additional to myocardial thickening. So when you contract, the myocardium should be thickened. And when you are relaxation during diastole, it should be thinned to be more compliant. So when we talk about, wall motion abnormalities, you want to know, number one, is all parts of the wall equally going towards the middle? And is the wall thickening during systole and thinning during diastole? Good. And of course, this is going to be a visual assessment. So with that being said, I couldn't resist by putting a couple of, bonus questions in there. So what about this critical care fellow is performing an emergent pericardiocentesis during PEA arrest, pulseless electrical activity? After inserting the needle through the pericardium, a significant amount of blood gushes out of the needle, and the fellow thinks, uh-oh, I just punctured the ventricle. This can't be good. What should the fellow do next? Should the fellow finish the procedure and insert the catheter? Remove the needle and attempt a different location? Remove the needle and quickly refer to Wikipedia. I'm going to tell everyone that is the wrong answer. Remove the needle and pretend to have a syncopal event. No, I wouldn't do that also. The right answer is going to be what? I know it sounds weird, but you got to finish the procedure. Insert that catheter because you want to try to tampen out that bleed, And I guess let's do a follow-up question. I couldn't resist this over here. And what do I see over here? This is going to be a pericardial effusion. This patient had tamponade physiology. This is someone trying to do a pericardiocentesis. Usually we do it ultrasound guided. But in the patient we're just talking about, which ventricle did the critical care fellow likely penetrate? The blood was gushing out, so it was probably going to be maybe I got you on this one. This one is going to be, it's the right ventricle. Why is it the right ventricle? Because what happens is that the left ventricle is very thickened over here. And because it's very thickened, when you could imagine a needle going in over here, it's going to actually kind of squish the bleed from happening. But if you do the right ventricle, blood will come out. So what are going to be some pearls for technique? So number one, when we talk about doing an echo in the ICU, of course, the best position is the left lateral decubitus. Easier said than done. Our patients are sick. They're on the ventilator. You can't really move them too much. As a rule of thumb, when you want to find the right image of the heart, start wide and deep and then kind of pull back and be more focused. Do very small movements with the probe. And, we always say that when someone's going to be overweight, obese, it's going to be hard to get good images. Thin people with emphysema are going to be hard to get good images too. Think of my emphysema patients. They have small rib spaces. They're cachectic. They have weight loss. And there's a lot of air in the chest. And remember, what is the enemy of the ultrasound? It's bone and what? And air. So it's not always going to be the patient that's going to be overweight that's going to be hard. When you start going to echo the heart, whether it's going to be for shock or whether it's going to be just to evaluate the heart itself, have a plan. And like I said, we went over the main images: parasternal long axis, parasternal short axis, apical four chamber, subcostals. Of course, if the patient can bend their knees, that would be great. And since you're down there, look at the inferior vena cava. And in a stable patient, which is not usually the medical ICU, don't rely only on one view. You want to look for the pathology in multiple views, not just one view, to help make a diagnosis. And of course, when we talk about how is the LV functioning, what do we talk about? It's the eyeball technique. We did mention other techniques such as the fractional shortening and all these, the fractional area of change and all these things, but that's not going to be what they ask on the board exams. I will talk very briefly about that when we talk about the right side of the heart coming up, but those are things that are not going to be tested on how you do it, and realize that eyeballing is going to be important. And of course, as a general tip, practice is very important, and hopefully by using some of these protocols and techniques, you could kind of figure out what's causing your patient to be in shock. And thank you very much. And I'm going to go through all how to get a hold of me when we talk about the next section, which is going to be the lung.